process it, you think of some questions or some things you can add. A lot of y'all have worked with patients already. I'm going to record this so you'll have this. There we go. All right. Here we go. All right, so we're talking about elimination, right? What is elimination? Exiting. What's exiting? Waste. What kind of waste? What kind of chemical waste? Oh, my goodness. Oh, the teeth. It's real easy.
Pee or poop.
Pee or poop. Thank you. Let's simplify it. It's level 1. We're not overanalyzing. We're talking about elimination is feces, bowel movement, or urine. Pee and poop. Okay? Alright, so when you have a patient that you're keeping up with their urine output, there's lots of ways we can do that. Tell me one of the ways. Foley catheter in a cup, we measure it, and we're measuring in mLs or cc's. They're both the same thing, right? You use a bedpan, and then you have to pour it because we want to know every milliliter or cc. What else? Urinal. It's got the measurements on the side. Good. The baby's little bag. Yeah, let me get that. Right, so we're going to make sure we measure that because urine is important, especially if you're a patient who's on IV fluids, because that's volume going in. We got to make sure we're measuring to see how much is coming out. And then if they're a kidney patient, like if they're in renal failure, it's important because if they aren't getting rid of their urine, where is it going to be? It's going to stay in the body, and then they're going to get too much fluid. They're going to start swelling. Their heart's going to get tired. They start getting puffy. They're getting toxic. So it's important to know how much is going in and how much is coming out. There's another kind of patient that we really, really have to be strict on our urine output measurements. Diabetics, but who else? What? Cardiac patients. Y'all doing cardiac yesterday. Because remember, if we have too much fluid, it's got that heart is your pump. It's just like a water pump. It's circulating that fluid. And if there's too much, that pump gets overloaded, right? And so that's when we see patients who are in CHF or have a weak heart, their pump is weak. So instead of it pumping through the body and circulating, it starts backing up into their fluids and into their lungs. Okay? So that's not good either. So always make sure that you're keeping up with intake and output. That's I know, especially on cardiac patients, renal patients, or somebody who's on dialysis, things like that, and you have an IV. When you're documenting your urine output, somebody tell me one thing you're going to write, you're going to chart about your urine output.
The color, the smell.
What else?
Clear,
cloudy. What else?
How much it was.
How much it was. Good. So all of that is important because if it's how much, first of all, we need to know the smell, because if it's real strong, it might have infection in it, or it could be really concentrated. So the color tells us if it's real dark, they're dehydrated probably, right? It should be the light color of like lemonade. You know what I mean? Real light. If it's too clear, then what do we got? We've put too much fluid in them, right? So the way you can tell about urine, and so you're going to chart all that, right? Color, consistency, that there's stuff floating around in it, because that could be protein or infection. Sediment is white blood cells. The amount, the color, the smell, the consistency, and then anything else, like if they're hurting, like if they say, oh, it burns so bad when I pee. Oh, that hurts so bad. You know, that's dysuria. D-Y-S means what? Difficulty, pain, yeah, hurt, difficulty with it. And then urea is urine, right? So urea, difficulty urinating, right? So that could be pain, burning, hurting, difficulty starting, anything that's dis. Because remember, going back to this, was dis. What's that one?
Difficulty breathing.
Right. So see how you can break those words down when you, if you know the basics. Right. Okay. So let's think about urine. This is how you can tell when the body is dehydrated. Okay, especially in our little elderly. We know they're highest risk, right? Why are they high risk anyway for being dehydrated. They don't drink. They don't like to drink. They may be scared, or they've forgotten, like if they have cognitive disabilities where they're forgetful, or they're going beginning stages of dementia. Maybe they're in a home situation where nobody helps them, or there is nothing there to drink, or they can't physically go get it themselves, right? So they have all these barriers to something simple as drinking water. So when you get them, and you might have to catheterize them because they can't urinate, they're having a dysuria, you catheterize them, and that urine comes out super, super dark. You think, that doesn't look good, because it's supposed to be the color of lemonade, right? Light lemonade. And so you can tell by the color of the urine how much fluid they have in their body. All right, does everybody know what concentrated orange juice is? Right, it comes in a can and it's frozen. Any of y'all youngsters had never had that? Okay. Comes in a can, that's why you get orange juice, right? 79 cents for a frozen can of orange juice. You dump that in your pitcher. You know when you first dump it in, it's thick, syrupy, dark, concentrated, right? That is what, think of as the body when it's dehydrated. That is what the blood and the urine are thick and concentrated and dark. Then, as we add water to our orange juice pitcher, or in the body's case, if we're adding fluids by mouth or by IV, what starts to happen once you add water to that orange juice? It starts diluting, right? Diffusing. Remember we talked about diffusing, and all that stuff starts mixing, and it gets a little bit more diluted, right? So when we get just the right level of fluid that we've added, what do we have? Perfect orange juice, or perfect hydration, whether it be urine or blood. Now what happens if I keep adding it? I'm diluting it, right? It's not as sweet, doesn't taste as good, it's too watery. Same with the body. If you're putting too much fluid in them, whether it be by mouth or by IV, you're going to dilute them. And then the urine looks white, like it's just clear like tap water. That means they've got too much fluid. You need to cut it off or give them a minute. Okay? Does that make sense? Go ahead.
What happens if you do have too much fluid? Like, is that a risk for something?
You can get water toxicity because our body has a normal balance. We need enough sodium and enough potassium and chloride. Those are our electrolytes that stay in balance at all times. When you're dehydrated, they look higher. When you draw blood, it'll look like, oh, it's too high. That's how we know when everything is elevated that they're dehydrated, if you hadn't already looked at their urine. When they're too hydrated, they have too much fluid, the urine will look real clear, but they have water toxicity. They will have confusion, disorientation. They may be sluggish. They can't even make words. They can't put thoughts together because we have overloaded them. They don't have enough electrolytes now to work on those synapses. Like the nerves and stuff, they need salt. And so if you dilute them too much with too much water, nothing was working. And you can do that. If you do that stupid water challenge where you have to drink a jug, try drinking 2 jugs. By the end of the day, you don't even know your name. So what does that do for your patient who's already a dementia patient or an elderly patient? We just put too much water in them. Now they're really confused, right? Now we're going to think, oh my God, they've had a stroke. We're going to send them off to CT. No. Look at their urine first. What does their urine look like? If it's crystal clear like somebody just turned on the tap water, they've been getting too much fluid. We need to stop for the fluids for a little bit. Make sure that they're getting plenty of food and that they're, leveling off. Okay? But yeah, too much of anything can always be. Even water can be too much. Okay, so any questions about urine and urine output?
So if they're not drinking a whole lot, like let's say they've had 32 ounces for the whole day, and their urine is still clear like that, does that mean we need to start looking at like what they're eating?
Or maybe what meds they're on. Because Lasix is a diuretic, okay? And what does Lasix make you do? What does a diuretic do? It pulls everything out of your tissue. So maybe they've had too much water or too much Lasix. And so they're not really overhydrated, but we're pouring it out of them. We're pulling that out of them so their urine looks clear. So maybe they go and look on the MAR and say, hey, did they get any diuretics last night or this morning? If they did, then oh, that explains it. That's why they're peeing so much. That's why their urine's so light. Yeah, okay. So it's the whole picture. We have to look at everything before we panic, But those are your clues. Remember I told y'all at the very beginning, y'all are detectives, and you have to look at all the body's clues it's giving you. All Alright, so how much is the normal urine output per hour? What should it normally be? You may remember from reading, because I know y'all all read. Per hour. UOP means urine output, right? 300. Not per hour. The minimum is 30 milliliters or 30 cc's. That's the same thing, milliliter to cc. The very minimum that the human body needs to put out per hour is 30. That's what the kidneys are, filtering is 30 cc's. If it drops below 30 cc's an hour, they're a little dry. Okay. So, with that being said, let's say your patient comes in and they've had 1,000 cc's. You pathed them, and they had 1,000 cc's in 1 hour. They're diuresing, aren't they? Diurese means to get rid of fluid. So diurese, just like diuretic. Diurese. That's not diurese. Maybe it's an I. I don't know. Something like that. Diurese. That looks right. I'm dyslexic this morning. So if they're diuresing, they're getting rid of fluid. So if they're having 1,000 cc's in 1 hour, and we know the minimum is 30, yikes, right? They're going. Okay. So again, going back to the Foley, we put the Foley in, and we're watching it, and boy, it's just pouring out of them. And it gets to 1,000. What do we need to do the next step? Remember how the bladder is smooth muscle, and it's been stretched out like a big water balloon. It's going to start spasming if we drop in that much urine that fast. So what do we need to do for a minute? Clamp that off, let them rest a minute, because 1,000 cc's in an hour, that's a lot. Unless they're like completely, so pitted edema. But even then, you would want to clamp it off, give their bladder time to rest a minute, especially if they're hurting. They're going to say, oh, God, my stomach hurts so bad. We expect that, because you just poured out 1,000 cc's in that fast, So just kind of know that the normal range for the very minimum that the kidneys need to be putting out per hour is 30 cc's. Okay? And then you're going to document, if your patient has a Foley, how much you got out, right? And then every hour you're watching how much it is. Urinary retention, remember we talked about that? The bladder is just full. It's getting a little bit out, but it never really empties completely. That's retention. It's holding it, just like detention. You're in holding. So retention is where the bladder is holding it for whatever reason. It might be you've got an infection, or you've got a blockage, like from a kidney stone or enlarged prostate, but they're retaining that water. They're holding that urine. And so they will have bad pain in their lower abdomen from the retention. We already said what happens when urine just sits for a long time. What does it grow? Bacteria. And so then they're going to be at high risk for what? A bladder infection or UTI. So those are the little people that you have to, really pay attention to. When you're doing bladder training, it's just like a toddler. You take them and you sit them down on the toilet every hour on the dot. Every 2 hours, whatever y'all have decided as a team. If it's somebody who is cognitively delayed or they've had some kind of spinal cord injury, you may not ever get that. But you do want to try bladder training, especially if it's somebody who maybe has just had a baby or they've had bladder surgery, something like that. Just know that bladder training, it can be done. You have to do it on a rigid schedule, though. Okay. What does urine do to the skin if they're incontinent? Burning, irritating. It's terrible on the skin. It can break them down and lead to what? Decubitus ulcer, skin breakdown. So tell me one of the things that they use now for skin if somebody's incontinent and in briefs. Skin barrier. Skin barrier. What's a common name? We used to use the different. Corona cream.
Our facility doesn't use Corona. They found out that I guess it doesn't work.
It's more aluminum or something?
Yeah, like they don't use Corona no more.
We use Desitin or Boudreaux's butt paste. We use nystatin cream. It's like the yellow.
Camelceptine, and then we have this like 1, 2, 3 stuff.
Okay. So it's like a chemical compound that they make up.
Is it like a pink and blue bottle?
Yes. No, one of them is blue and white, and it's super thick.
Yeah, ours are super thick.
It's hard to clean up.
I can't think of the name. I can't think of the name.
So there's lots of different kinds though, right?
Yeah.
So whatever your facility is using, you want to make make sure that when you clean your patient, after you've cleaned up, changed their brief, you're cleaning their skin good, right? Are you scrubbing it? No, because that skin's already tender. So use whatever they say, like the cloths or the wipes. And if it's got alcohol base, it's going to burn, especially if they've got a raw, just like a baby that gets a bad diaper rash. So then, after you've cleaned all that urine off that's burning, especially if they're dehydrated, that urine is super strong. It's that concentrated orange juice on them. And so it's, you clean them good, and then you put that cream on them, and you want to do more frequent changes, maybe, especially if they're having a lot of urine output. They're diuresing. You don't want to let them lay there for 4 hours, okay? All right, so just know, and that's for BM, too, for bowel movements or feces. You want to make sure you're changing them more frequently when they have that on there. We do not want that on their skin. Okay, so now, any questions on urine? I think we kind of covered that. Now I have to go potty. Makes me pee-pee. What if you have a patient who, we talked about this a little bit, has a catheter and they're kind of confused, disoriented, but they have to have that catheter in. What are you going to do to keep them from pulling it out? Not much, huh? If they want to, they will get to it, won't they? They will pull it right out. Well, not for something that's like that. If it's just temporary, maybe just for an hour, that you're having the catheter in, they might. But if it's going to be long term, you have to give them some kind of diversion technique, maybe something to give them to do with their hands. But if it's hurting them bad enough, because those things burn and hurt, it's irritating. So you just have to keep checking on them, and you may have to put it in and out multiple times, and that's unfortunate. What's the kind of catheter that we use for a patient who has an enlarged prostate? What's it called? No.
It's a Coudet.
It's a stiffy.
It's a Coudet.
Coudet.
Yeah, that's right.
It's a real stiff one. Remember it has wire in it? Here it is. COUDE. It's really stiff. Because remember, you've got the Foley, the normal one that we put in everybody, the usual one. Look at it. It's like a wet noodle. Can this go in and do anything if I had a blockage? I have to use this one that stands up. That's a stiffy. I have to get a stiffy in the stiffy, okay? Remember it that way. It's called a Coudet. The red one is just to put in and out. That's right. It doesn't have a balloon, so we can't inflate it and it wouldn't stay. So the red one is just for, I'm getting a specimen. They can't pee in the cup for me, so I got to put this in, let the urine drain out in my specimen cup, and then I can take that red one out.
Question is off the subject.
I'm shocked. You off the subject?
It's probably about the stiffy.
So when Sunday don't want to pee, would y'all gonna give her the red
I
one?
cannot talk about any of that. Some indications. It just depends. Okay. So Coudets are for the ones that are, for enlarged prostate. If they're having trouble now, tell me what would be a symptom of enlarged prostate. Remember the little picture of the little man and he's just dripping? Did I give y'all that picture?
Yes.
He's dripping. Are they going to get up and pee a lot during the night?
Yes.
So they're going to have nocturia. Noct means night or nocturnal. Urea. Is it EA or IA? I'm bad. This looks sick today. So nocturia means to get up and pee at night a lot. Because he is never really emptying his bladder, is he? It's just trickling out in drops. And so, because his prostate's blocking it, it can't drain out. And so they'll have nocturia when they have enlarged prostate. Okay? And so then he says, I'm getting up peeing at night all the time. I can only get a few drops out at a time every 15 minutes. So he's having frequency. He's going a lot, but he's not getting a lot out. What's some other symptoms of it? Do you think he's retention he's holding? So what's he going to get? He's holding my urine. A lot of UTIs, maybe burning. Okay. What was that? What did you say? I didn't catch you.
I don't know.
Yes, you do. Say it. I forgot. Alright, so just think about that. If you had something squeezing your urine outlet, you're going to hold water, you're going to be at risk for infection, you're only going to have drops out, and then you're going to be going all night. Same with a lady. If she's got some kind of blockage, she's going to be urinating all night and all the time, but it's only a little bit of urine. Okay, that's retention. And then we know the Foley cast. Those are what we put in. That's going to stay long term. They have the balloon with 10 cc's of sterile water. And do we put those in sterilely or clean? Sterile. If I put it in the hoo-ha, am I in the right place? No. Where does it have to be in? The urethra. And so, remember our landmarks. Those are internal labia. Y'all know labia is? Y'all know what labia is? There's your clitoris. And then there's the urethra. It's kind of like a little hood of skin. And then the vagina. And then the... Yeah. So just know those. That way when you look, you visualize it first before you go in, because once you go in, if you're not in the right spot, you got to start all over.
Why do they say it winks at you?
Yeah. Because it's like a hood of skin, and when you put that cold swab of povidone iodine on it, the cold makes it contracted, so the skin shrinks down and it looks like it's winking out. The urethra. The urethra. I'm not talking about anything else winking. I don't know about that.
holes?
You have your clitoris at the top. It's not a hole. It's just, and actually, it's a female penis. When we're born, we have XY chromosomes, and so, or X and X, so it's kind of like a little appendage. And then you have, it's for sexual stimulation. That's why, intercourse feels good. Then you have the urethra where the urine comes out. That is a hole because that's where it's coming from the bladder. You got the vagina, where it's attached to your uterus. That's where the baby grows inside the uterus. So once the baby's coming out, it comes out the vaginal opening. And then you got your anus, which is where your solid waste or your feces comes out. All right. That's the basic female anatomy. Let's see what else.
She's like, I'm missing a hole.
Yeah, she's like, wait a minute. Hold up.
I've been gypped.
News flash. Which one is the kind of catheter that you might see this on a test question on your NCLEX later on down the road? That they use, like, let's say our patients have the TERP, where his prostate's been so enlarged, now we figured it out, and we're going to pull it apart, and he's having all that bloody body urine, and then we have the irrigating, but he's going to have a catheter with it's going to have 3 lumens, but what's the name of it? Robinson. You can remember that because it's close to my name. Since we talked about P. So always remember, Robinson is the three lumen catheter that one has got urine coming out, and the other one's got the clean water going in that's going to flush them out. And the third luminous or something. Alright, so I feel like y'all are good on all that. Any questions on urine output, or anybody that's got any kind of things that we want to talk about on that? What's the one kind of catheter that's not invasive? Like doesn't go in the body? Condom catheter. Very good. And what's my high risk for that? One, we know it's not probably on stone real good. But it's circulation and breakdown. Because my skin is sitting right on that urine, or that urine sitting right on my skin. And then I've got that band holding it on. If the nurse puts it on too tight, what's going to happen to my little circulation? My little appendage is not to get any blood, is it? That could hurt me. So always check for skin breakdown and making sure that appendage is getting circulation with a condom catheter. Alright? Self-cath, that's for somebody who's kind of long-term, they've maybe had an injury and surgery, now they're homebound or they're at home, and we're making sure to teach them good cath technique, right? Teaching them to be sterile as much as possible and how to take care of that.
When you had your surgery, if you wouldn't have that into your bladder, would you have to have that?
Well, I'll tell you that I had a fistula as a whole.
You had it out here.
No, I just had the catheter out here. I didn't have a uroscopy. I just had a catheter that went into my bladder, through my abdominal wall. But the fistula had formed when he sewed me between the vaginal cuff and my bladder. So I had urine leaking out of my vagina. And that's why I was like, this isn't right. Like, I know I'm a nurse, but you're the doctor. That was the first mistake I made. I know I'm a nurse and I'm just a nurse and you're the doctor. I'm sorry. Don't ever, ever, ever say that to yourself. I knew better, and I still listened to him because he was a doctor. And I know that they have a lot more training than we do, but sometimes you just know your body, and you know anatomy. You're a woman, you know your body, and if things are not working like they used to work, go to somebody who will listen to you. Okay? So that was my first mistake, was listening to him and believing him. All right, so when you're self-capping, you're just going to teach them how to do proper technique, clean, sterile technique. Try to keep everything clean as much as you can in a home setting. Spinal cord injuries, people who have neurogenic bladders, things like that, maybe they've had cancer, and the nerves that go to the bladder aren't working anymore, so they don't feel when they need to go urinate, so you have to self-cap. All right. How far down the catheter, like let's say the Foley's in the person, how far down the catheter do we clean? 2 inches. So if here's the body, and here's my catheter coming out, I clean 2 inches down, right? 2 inches is about two sections of your finger. See those little sections on your fingers? Those are approximately 1 inch. So that's your easy way to measure. Okay. So about 2 inches down, we clean with our betadine swab or whatever they tell us to do at our facility. Each time we're changing them, right? And that's something. Can you delegate that to a CNA?
No.
Oh, yes. You could. If you show them the first time and you demonstrate it, and then give them, let them return demonstrate it. That's not because they're the ones that are changing it. The nurse doesn't have to run in there every time and swab. You can show them that, but you have to explain to them how important it is, because they've not been in nursing school yet, so they don't understand that the microorganisms are going to go up and the urine tract's sterile. They don't get that yet. So you have to explain it to them and show them how to do it. Okay? Any kind of pus in the urine, what's that called? Pyuria? Not the other way. Remember we talked about how not to spell it. Pus in the urine, any kind of discharge or drainage or odor like that means what? Infection. Right. Pus anywhere. Infection. All the time. Okay? Alright, so when I have the Foley catheter bag, and it's, let's say they're going in a wheelchair, can I put that catheter bag in their lap? No. Not for long, because if they're going to sit for 2 hours, is that urine going to drain up? No, it drains down. It goes with gravity. So I never put the Foley bag higher than their bladder, because then gravity is not going to go upward. So you need to have it low. Now, while they're rolling, absolutely, because do we want that thing to get hung in the wheelchair wheel and snatch it out of their bladder? No. So when you're transferring them for a short distance, yes, you keep it in their lap. But once you get settled and you're going to be in the place they're going to be, that urine bag needs to be lower than their bladder so that gravity can let the urine flow out. We don't want to put it on the floor, though, so find a way to, keep it where it's
I've been
hanging.
to ask this with the bulb. Can it ever go down as
Sometimes they can deteriorate. If the urine is strong enough, it will can eat and erode through that, but very seldom. They can deflate though. And then it'll just slip out. And then you walk in and you're like, why's the bed all wet? What? And then you realize, oh my God, the catheter came out. So, or they pull them out and it deflates that way too.
What about when they pull it out and the bulb is still, everything is still
Intact. You should be looking at their urethra, because that's going to be painful. And so make sure that they haven't torn anything, or they're not bleeding or causing more trauma. And then, you go and report it, and then you go get a fresh one, and you have to start all over. And again, that's with those dementia patients. It's hard to make them not pull that out. They don't remember.
Think about how to time machine when he gone that trip and snatched that catheter out, and he got pee all over him. This will make me think one thing.
All right, what kind of exercises do we do to help with incontinence? Fetal exercises.
One more question.
Okay.
Let's say they do yank it out and there is trauma. Is that completely up to the doctor after that, or will we be
You assess them, because you're going to need to see what's the damage. And then you go and chart it, and then you're going to call the doctor and say, Ms. So-and-so or Mr. So-and-so has pulled out the catheter again. Normally, I would always let them just rest. I would put a chucks on them or pull up a brief, and I would let them just be that way, for a couple of hours, because they just pulled that out. It's going to be so traumatic, and now I've got to ram another one right back up there. It's going to be so painful. It's just up to you. It's up to your best nursing judgment. Always talk to your other nurses who've been around and see what they think about it. You have like a little mini meeting, and then you can always refer to your nurse practitioner or doctor and see what they want to do. They may have said, hey, just keep it out. If they pulled it out 4 times, we're doing more damage by putting it right back in.
Yeah.
So they may just say, just leave it out, just leave it out. No. Because we ultimately do not want to do damage to them, right? Or as least amount as possible. Okay, let's take a break from urine, and then we'll come back and talk about poo-poo, and then we're going to do something else.
So yesterday, this like has nothing to do with kind of this. But I was talking to my doctor, and he was telling me that he got some equipment in my limit, and he was telling me that he has for ladies now. What is it? Usually women only have one treatment, but there's 3.
Where does the body go? Where is it?
It goes into the vagina
in the vagina?
and onto the labia. And it has electrical stimulation, and it makes it warm. And it makes the collagen grow, and it makes the muscles around the bladder tighten.
Multi-use. Yes, ma'am. Yes, ma'am, 1 and 2.
I hear it on my dressing now, it's a knock there.
Alright, what do you think the knot's from?
Takes a keloid.
You're cracking me up. I'm so proud of your terminology, but what do you think, seriously, what do you think that is? Think about your when you get a wound.
Inflammation.
She jumped you. You gotta have inflammation. So all your blood's going there, all those white blood cells, all that.
They're trying to fix it.
Yep,
It ain't
trying to
working.
repair. That does hurt.
Let me be.
So you need to take an anti-inflammatory and tell them, knock it off, I got this. All I need is Motrin.
You know the ones that turn into stick? That's what it looks like. It's like,
So are they like trial, or is it the real now?
it's his. Like,
How much are they?
I didn't ask for that. He's like, if you know anyone, because he's like #1 in the kids.
I'll try it.
And you can tell him I sent you over.
Because when I had the first surgery, okay, I had a hysterectomy, and then after, I had that in June, and then by November I was like, this is getting worse, because the fistulas actually didn't work, and by the time they found it, it was the size of a nickel. So it went from the pinpoint of a suture needle to the size of a nickel. So at first I was like, oh, that's just a little bit of drainage, like, serous drainage, or, I didn't think it was anything. And then it kept getting more and more to the point where I had to wear a pad. And so he's like, oh, you're just having stress incontinence, because when you have your hysterectomy, the uterus is gone, so the bladder flops over. And it's just making you have urinary incontinence. And I was like, in my head I was thinking, no, because it's not like I feel it at all. I couldn't ever feel it. And this was my other sign. I never had that sensation of feeling full in my bladder. You know how when you have to get full and you're like, okay, that's your signal to go pee. I never ever felt like that. All I would stand up and just feel a gush, or I would just feel a trickle all the time. So I never had that sensation of pee. When I started putting the puzzle pieces together, I was like, no, and I gave him all these examples and logical things, and he was like, no, you have stress incontinence. And so he went and did a bladder tack and used that mesh, which then, now, that's all terrible, and so now that is eroding away, and I'm at risk for bladder cancer. And so, and it wasn't even necessary. So it actually, my bladder was where it needed to be, and now it's pinching it to where I have to go more frequently, because it's compressing it. It won't ever let it expand like it normally would have, had there not been a hole there just constantly leaking. So after that thing, and after 6 weeks, I had to have a catheter during Thanksgiving, I remember it, and through Christmas, and then finally went back and got the Foley out, and I was like, this is not getting better. This is not getting better. Something else is wrong. You need to, look again. And he was like, you just have stress incontinence. It's normal after a hysterectomy. And I was like, that was like right at 40. I was 37 or 38 when this happened. And I said, I am not having stress incontinence. I'm too young to have stress incontinence. And don't sneeze and pee. I'm not having the normal stress incontinence that you're trying to label it with. And he was like, I don't know what to tell you. He was really a jerk. And so I was like, you know what? I just need my records and I need to go. So I said, I kept telling him I think I have a fistula, because it was the symptoms I was having were exactly what a fistula does. And the only way I knew that that's what it was because when I was working in the ER, we had this little elderly lady that came from a nursing home, and she was septic, uroseptic, which is common for them to get bad bladder infections. And so we went to catheterize her to start our thing. So we were just going to admit her. And when we cathetered her, feces was coming out of her vagina. And I was like, my friend was working, I was over doing something else, and she said, "Come here, look at this. This is normal. This is normal. Why is this coming out?" I was like, "There's no way. There's no way that's coming out." Because I wasn't thinking, we just thought she was uroseptic. So we looked, double checked, sure enough, she was having feces come out. So we went and told the doctor, and he's like, "Oh, she's had family," finally got a hold of family, they were out of state. She'd had cancer, and it had eroded that wall between her rectum and her vagina. So that was a fistula, an opening. And so when she had bowel movement, it was coming out of both places. And when I realized, I was like, okay, I'm standing up and yours coming out of my vagina. I have a vaginal, fistula, vaginal fistula. Had to be. And then that lady came to my mind, and I was like, oh my God. And so I told him that, and he was like, no, he didn't want to hear it from me because I'm just a nurse. So I went to a doctor, and first thing when he examined me, "Yep, you got a fistula, you're right. It's the size of a nickel." And I was like, oh my God. 6 months of my life, me telling him that, being miserable, not being able to function in life. I was like suicide. I remember getting up. I had to sleep on pads because I didn't want to ruin our mattress. My husband was just like, there was nothing going on. And I was like, it was awful. Just the whole gamut awful. And I told him, I was like, you've ruined my life. I'm to the point where I got up when I could pee because I just was so tired of feeling it trickle out. And I just thought, okay, just go in here and sit. It'll come out. And I remember sitting on the toilet being suicidal. Like, I can't live like this. I'm not even 40. And my life is over. And I was like seriously thinking about just driving into a tree. And so that made me more upset than anything that he got me to that point. He did not listen to me. He did not listen to his patient. And so I told him, I was like, I need my stuff right now. And I got my records and I left and went to the doctor and sure enough, another one that dealt with just those types of issues. And he said, yep, you have fistula. Size of a nickel.
Well, you should go see Dr. Science, and you should let us all know, because he said that the women see results immediately.
Well, and that's what I'm wondering, because when they did the bladder, all of that to say, when they did the bladder tack, he shaved off part of my back vaginal wall. He used the tissue to help support that. So I have a very thin wall. I'll probably develop a rectal vaginal fistula one day, because there's hardly anything there. There's no muscle there.
Well, I wonder, if it, since it, stimulates, the growth, then, maybe it'll,
So ask him about it. See if he thinks that'll help.
Okay.
It was horrible, and that's why I feel like you have to be, as a nurse, you have to listen, and you have to be supportive, because those doctors won't, especially a male doctor with female issues, they do not understand our body. It's anatomy to them, and they don't get it.
He's an internal doctor. He's an immunologist, and then he has his own spa where he does all this classes.
Interesting to hear what he has to say, but listen to your patients, and as the nurse, you go in there and say, I'm sorry, and you refer, hey, have you ever heard of this doctor? He's really good. Here's who I use, for a gynecologist. Or on the side. Do that.
We had a good nurse that she wanted us to take Ritalin because he had paralysis of his intestines, and then he would not. Our doctor would not. He was like, oh no, he doesn't. That's for heartburn.
No, it can be used for everything.
Because that you would not be a patient needed for that. Did not listen to us, and then we went to another hospital. That was the first drug they started him on with erythromycin because it would stimulate his intestines.
Yeah, because those make you go. It's amazing because some doctors are just.
She's like, don't tell him I told you that, but just saying.
Here's you some information.
Yeah.
She was being a resource for him because she realized that's not right.
Yeah, and she's like, I can't tell him, but you just say that you were looking at things online or something, and you want to recommend this for him. And she
was looking out for the patient, not for ego, and not his ego.
You still have the mesh?
It's that tape, transvaginal tape. And then when I went to that specialist, the one that finally agreed, yes, you have fistula, there was a whole waiting room for women there. And, we're all looking like we're about ready to kill ourselves. You could tell. I recognized the look on their face because that's how I felt.
I'm not alone.
And, yeah, I was like, oh, but then it shocked me because I was like, oh, my God, all of these women in here have been told probably the same crap I did. And I was told, and it was an easy fix, but it was a just it's a horrible. The whole situation was horrible experience. But then she was like, you need to tell him, and I will one day. I think that's part of why I didn't sue him either, because I didn't want to have to go to court and tell everybody. That's so private and personal and embarrassing. But I had nothing. Now I look back, I had nothing to do with it. He did that, not me.
If you feel anything over there like that, just type it in there.
Yeah, the translator will take a bladder pack. Okay. So would y'all want to do a field trip next Wednesday?
Yes.
For the grocery store?
Yes.
Scavenger. Really? Lame! Lame, but out here. Okay, we'll sit class and stare at each other. You can coffee or something over there.
Where are you gonna go, Brian? Where are we gonna go to Market? Let's go to Market Street.
No, let's go to Sprouts. I've never been there.
Sprouts is it's all health food.
Yeah.
And so that would be hard because I want to show y'all I wanted y'all to find the difference. I'm gonna give y'all a list of foods that you have to be on a scavenger hunt for. Break y'all into teams and you have to take a picture of it and we're gonna learn the nutritional labels and all that.
I don't know.
It is
Pretty
great.
sure whatever you want to do.
We can go right up here to Market Street and then we can have our post. You know, we can finish the rest of class in the little deli area.
They got some good food.
I love their food. That's the nicest grocery stores I've ever been in. They love it.
I've been shopping there. But
No, it's not.
Where's the nicest ones?
Amigos.
No.
Where on about University? I've never been there, but I heard they're cheaper. I heard they're cheaper.
I walked up in there and they had the little biscuit music going and stuff. I was like,
Where you going?
yeah, but this one Spanish
I always think when I dance.
this one Spanish lady, you know how they got them big old bread things and they pink and yellow. And she was like, these are good, mija.
Well, that's where we can go. We can go to Mika's. I was just thinking because it's right here on 50th, but we could go.
Good things is sweet. I'm getting $20.
What's it called?
It's a bundle set. The one she's talking about is a horchata.
It's like pink and yellow.
What is it?
They're good with coffee.
Like bread, I guess. I don't know.
We could go to Mika's for a cultural considerations field trip. We can do that. So I can learn. Because I love
We have an Amigos in Plainview, and it's way nicer than the one here. Like, that one is the one everyone have pizza on Market Street. So it's 2 blocks from my house, but I will drive across town and go to Amigos because it's so much cheaper.
Yeah, I've heard that too.
It's so much cheaper, but it's way nicer.
It's the best place to buy sweet bread. It's Frisco's Bakery.
Yes.
Where?
Frisco's Bakery.
Feel free to bring us a sample. Oh, your hair looks good, Beefy Dubs. Did she say anything?
She just said that she didn't have a problem with it, but she was afraid for misfits to have a problem. She didn't want to have a problem with misfits. So if I wanted to, I could, but I'm going to take that risk of misfits home. So I was just like, I'll just.
Or Miss Shelton, she's even more of a hard.
Yeah, and I was just like, no, I'll just go home and just get out.
It's just either. I gotta go get mine done too. I was looking.
Your hair actually looks good.
I curled it today. I got a 3rd-degree burn on my ear from the curler, but it's whatever. It's what I do for y'all. That stupid curling iron. I was like, oh my god. And then I tried to get away from my ear and it hit my neck. Did everybody get the little handout about the little man? Cooper Scooper. If you didn't, I think there's a few over there, and I have one. Everybody get to use the bathroom and get a break.
I'm not gonna lie, you know who you remind me of?
So when you have incontinence, can it be lots of different kinds?
Yes. You're in here saying that.
I'm having trouble spelling today.
That's
It looks like I'm having a stroke. I know, Crystal. What's going on?
7 o'clock. And you
Yeah,
got out of the
and-
car and walked somewhere.
Yeah, I went over there to mail my bills off at that thing right there. They dropped my bills off over there. Mailbox, because I don't trust my mailbox. People snatch stuff out of your mailbox, especially at Christmas. Be careful.
Yeah, packages.
And then
We got our bikes stolen off our porch last
I
week.
had, yeah, we
As
had
soon as
packages.
Amazon delivered them, we were home in 5 minutes. They already been stolen.
yeah, it's crazy during Christmas. So I don't trust my
Except people follow the FedEx.
They do.
Mm-hmm.
But Amazon replaced them with food. Even though it wasn't their fault.
Alright, so you can have fecal incontinence. What's fecal incontinence? Feces, fecal, or urine incontinence, urinary. Alright, and then if it's urinary, there's lots of ways you can have stress incontinence. Where's that one? What's that one? Where you sneeze or cough and little drop or two coming out.
Like when you're pregnant.
Yeah, pregnancy, obesity, because it's pushing down on that bladder. Or if you have multiple births, it stretches that sphincter out, that muscle that keeps it tight, so it will leak out. Okay, that's stress incontinence.
Well, the lady from 19 Kids in County, you think she has it?
Oh my gosh.
You know she
Some stitches put in.
You probably can't even smell without getting
Yeah, she can't laugh or do anything. Alright, and then what was the other kind of incontinence? Urge incontinence. What do you think that is?
where you be like, oh my God,
Constantly
so bad.
Yes, you feel like, oh my god, I gotta go, but you can't make it sometimes, or it's just like it just feels sudden urge to go. You can't ever really get through that feeling of got to go pee. What's another kind of incontinence?
Overflow.
Mixed. I think that's kind of a combination of both of those.
Overflow.
And then overflow is where what? What happens? The bladder's too full. Something's blocking it, and so the bladder just fills up, and finally it's just like a water balloon that I've stretched as much as I can stretch, and it just lets it go. And so that's when you have overflow. Okay.
So what if you was in the store trying to get your groceries?
You better run. I've had to stand like this many a times. Like I feel a sneeze coming on, and I'm like, oh my God. Like you see women in the halls or the aisles, you know. Lady, the bathroom's right over there. Yeah, just don't let them know. Okay, so when you're having all those different kinds of incontinence, just know that that's, you know, from loss of motor control or muscle movement, muscle control there from different things, okay? And it's in your book. You can go through them.
Why did you like stretch out whatever whenever you have a lot of kids?
Well, because
Look at your body.
there's a sphincter or muscle that holds at the end of your bladder. So here's your kidneys, here's your ureters that drain the urine from your kidneys to your bladder. Right here's your urethra where it comes out, right? There's a little sphincter muscle right there. It's like a little tight, almost like your anus. It's a sphincter. Real tight. It's a tight muscle. And over time, from having babies and the bladder's always being full, if you don't empty your bladder frequently enough, all that urine is pressing down on that sphincter, putting pressure on it. Okay? The muscle loosens just like any other muscle, and it's going to relax. And so you don't have as much control in it.
So when you're doing the Kegel exercise,
It
and
strengthens that
tighten it?
sphincter. Exactly. Exactly.
So did you start doing it like when you
I
started?
try to do them after I had my babies and stuff, you know, because I did have stress incontinence. But then after I had the surgeries to fix everything, they helped, you know, tighten that back up too.
Like, sew that right up this pharmacy?
They put it, yeah, they pull it up, tighten it up. Can't have any more babies, so it's a good thing. Win-win. All right, so just know, like I said, there's different kinds of incontinence. Now, fecal incontinence, we kind of talked about that. That's where the same thing. Instead of that urinary sphincter that we did Kegels for is loosened up, now our bowel has a sphincter too, right here at the anus, and it is not working, is it? So they have this muscle here, that sphincter, at the end of the GI tract, at the end of the colon, it's loose, and so they may have to have a bowel movement.
That from like having anal sex.
Yeah, I knew you were going to say that.
That's what happened.
It was coming out of my mouth, I was about to say, yeah. Yeah, exactly.
So what do like gay men? What do they do like?
Well, they have
Do they know that's going to happen?
Yeah,
to them?
I mean, they relax that sphincter. They take medicine to relax it. and then they can have plugs. They're like a thing that goes in there. So
Tampon and they
similar, it's like a plug. Another thing that can happen is just with age. You don't have to be homosexual. It can just deteriorate like every other muscle, and so they have loose control over their bowels. That's why elderlies, they become bowel and bladder incontinent because those muscles have just deteriorated.
Can you do Kegels for them too? Can you do Kegels for your butt?
Gluteal squeezes. I don't know if that'd help. But just know that's what's happening. That sphincter has become atrophied or deteriorated. And so it's going to come out, right? Come out a lot easier. Same thing. They may sneeze and have a code brown. You never know. So you just have to be real cautious and try to help them, get cleaned up if that happens. A lot of times medicines can make that relax. Because remember, what is our bowel made out of? It's muscle. So if you're taking muscle relaxers, guess what? This one's a muscle. Guess what relaxes? That's why you have a real soft, easy bowel movements when you're on those kind of meds. Alright, so just think about that. Remember we talked about having hard stool up high? What is that called? Impaction. And then you can have them down low sometimes. So if it's down low, what is our treatment? Yeah, we can give them a first try stool softener, or try to go up just to as far as our fingers reach. We're not going to go elbow deep. Right here, if we feel it, we can try to remove it carefully. Not very long, because what are we stimulating? Vagal nerve, and we don't want to do that because that's going to lower our heart rate on. So if we can't feel it, then we could try stool softeners, suppositories, maybe an enema. What position does your patient need to be laying in for an enema? Sims, left side, right? Why do they need to be on their left side? Because here's my right side. It's going up on the right. Transverse goes across because it's like one-way traffic, right? It's one way. And then it's coming down on the left side, descending. So if I'm on the left side, I need to be laying on the left side with my knee up in the Sims position so that solution that we're putting in sits in the bowel, and then gravity pulls it right back out. Okay? If you're laying on the right side, you're fighting it. You're fighting gravity. So always be on the left side and with their knee up in the Sims position when you're giving an enema. And again, don't stay in there 45 minutes with the, give them time to relax in between. You're going to be assessing their vital signs and heart rate, respiratory rate, looking at their skin and all that, because we don't want to bottom them out. When you're constipated, not just impacted, but you're just constipated, tell me some of the reasons that you can be constipated. Dehydration. What else? Medications. Good. What else? What kind of medications? Pain meds. What else? Iron. Good. Iron is, if you don't know the FeSO4, I think is iron sulfate, ferrous sulfate. If you see that, that's iron. If you know, for farm.
You get constipated if you're just laying there.
Yes, immobility. Good. What else? Good. I was going to say, what if I just eat carbs all day, every day? That's not fiber, so it's going to bulk up and turn into a constipation of possible impaction. So tell me some high fiber foods. Bread. Oh, go ahead.
Apple a day, broccoli and carrots.
Broccoli, carrots, apples, anything raw and crunchy. So remember that when we go on our scavenger hunt. What else? Oatmeal. You think of bran or bulk? What did I eat? Prunes. 2 or 3 prunes will get you going. Warm liquids. That's your go juice, like coffee or warm tea. That'll make you go. Okay. So those are things that if your patient's constipated, you want to make sure that you're checking. What happens when I'm impacted and maybe the stool is still oozing around there?
Diarrhea.
Yeah, that's going to be presented as runny diarrhea. So we want to make sure that they're not impacted, or if it's been several days of runny diarrhea, we definitely need to report that. Sometimes antibiotics can cause diarrhea because it's just killing all the bacteria in your colon, so it flushes through.
There was this man on my home, and they always sleep. Their stomach is always real big. I was having diarrhea, and then they said he was still impacted up high. And I was like, like, how is that when you're always pooping? But now I'm good.
Mm-hmm. They should have done an X-ray because you can
That'll
see
curve that
stools
IUD.
on an X-ray. It shows up hard, like a bone.
They don't care.
Where was that at?
At my job.
Other kind of meds that can constipate, especially if they're mental health, a lot of those meds, remember, if they're manic or they're hyper or they have something going on mentally that we're trying to suppress and calm down, it's a suppressant, so guess what else it does? It slows everything down, including your bowels, so they will get constipated too. So probably what happens when they're taking it daily for years, they can get constipated. Meds are tough. It's not healthy
One of the
sometimes.
nurses said because like they've been fleeing him for years that
Now he's
it's not
electrolyte
working,
imbalance.
and he can't use the bathroom without like.
They need it. So what should they have done instead of just constantly fleeing him? When it doesn't work after
maybe
2
push
times, don't keep doing it.
fluids,
Come up with something
They sent him
else.
to the hospital once and they put their finger in his butt.
Digital exam to check for impaction. But what else could she do? Nursing measures. We just talked about it. High fiber diet. What were they feeding him? Did they look at his diet? Probably nothing with fiber.
Nothing.
So they could have said, hey, instead of us giving him grits today or oatmeal, let's give him some high fiber cereal for lunch. Instead of giving him a hamburger and french fries, let's give him a big old green salad with lots of broccoli and carrots in it. You know, alternate. Don't keep doing the same thing if it's not working. Your job as a nurse is to be an interventionist and find a solution. So having a fleece, all I did was probably dehydrating more and
And he
messing
don't
with
like to drink
electrolytes.
water, so.
So they could come up with Gatorade or some flavored water, something. You have to have a solution for every problem. You have to. And if you can't come up with one, you go talk to somebody else and maybe they can come up with something. Alright, give patients options. Alright, so then another reason that they may be impacted, like we said, they're constipated, bad diet or meds. What else? What else could be blocking this go train? Brown train. Polyp, cancer, right? Some kind of growth. What about inflammatory bowel disease, where they've got the inflammation on the inside lining of that colon, and so just like the prostate, it's squeezing, so less can come through, right? And then it blocks up. When they have GI bleeding, it's going to be somewhere along this track, right? This GI tract. We want to watch real close for blood in the stool. What color is the stool going to be if they have a lot of blood in it? Well, it'll have bright red on the outside, but what does dark, tarry stools mean blood? Dark, like they're black and they're tarry, like looks like wet tar. That is the hemoglobin coming out with the bowel movement. And so they're dark and tarry, and they smell real strong. If you ever go and have a patient with a GI bleed, or if there's anyone in the hallway that has a GI bleed, you will smell it and you will never forget that smell. The smell of blood coming through the bowels is like a very distinctive smell, and you can smell it as soon as you get off the elevator. You're like, oh, somebody's got a GI bleed today, and so it's real strong. So just remember that in case you're ever, when y'all go to clinicals, if somebody has a GI bleed, let everybody in the class can smell it, so y'all can never forget that smell. Okay, it almost smells like pennies, like dark, dirty pennies, real metallic. All right, so when we're looking for GI bleeds, like I said, they're going to have dark tarry stools. They may have a little bit of blood when they wipe, but that could be what? Yeah, that could just be a hemorrhoid. But if it's bright red, excessive, it's filling up the toilet with bright red blood, or the stools are very dark and tarry, then we think, something's wrong. What's my vital sign that I can check to see if they're losing a lot of blood? Blood pressure. The blood pressure is real low. On top of they just emptied out their bowels and they're bright red in the toilet, I need to be checking their vital signs because they're losing a lot of blood. Now, the one exception to that dark tarry stool thing is, we talk about iron, ferrous sulfate. Its side effect is to make you constipated, but it does make your stools dark because what is it? It's building blood. So if you're taking iron tablets, then you automatically are going to have dark tarry stools because that's the iron coming through, the extra iron that your body didn't need, it excretes it out. So that's normal if you're taking iron. So when you look at somebody's bowel movement and it's dark and tarry, you go, oh, do you take an iron pill every day? Yes, I do. And you're like, okay, that explains that. But if you look at it and it's dark and tarry, you say, oh, do you take an iron pill every day? And they say, no, I don't. That's trouble, right? That's the difference. Okay? So always check for blood in the stools, dizziness, pallor, high heart rate, low blood pressure. They're losing blood. Okay? And what's the test that we check for on their stools for that? Chemical cards, right? 3 little cards, 3 different samples of food. Okay.
What about if your stool is white?
They probably are taking like a milk and magnesia or something that's real chalky, like an antacid. It could be that, or they just had a real bad high impaction that just worked itself out. Let me see. Can you have acute diarrhea? Yes, like a virus. If you're having acute diarrhea and you've got a stomach ache, do we want to take something like, oh, let's stop that? We want to take something that stops diarrhea, an antidiarrheal. No, why not? If it's a virus, remember back to our first week, we want to get that out. The body recognizes that and says, oh my God, there's that stray cat. Get it out, right? Get rid of it. And so that is why you have diarrhea when you have a stomach virus, because the body knows it's something I don't need and it's shooting it through you fast, okay? So if your patient's got a stomach virus and they're having explosive diarrhea, say, I know it's awful, but we need to get it out. We need to get that out, okay? Now, they're losing a lot of fluid that way, so what do we need to give them? Replace their fluids, right? Gatorade or fluids, good. Now, if it's chronic diarrhea, that could be from meds or a blockage or something like that. We already talked about that. Can they have acute constipation? That sounds crazy, doesn't it? Because constipation we think is chronic, and it is. But you can't have acute. It's a sudden onset. From what? What could happen that makes them have acute constipation? Something's happened, right? Stress. All of a sudden there's surgery because the bowels have locked down, or they've gotten in a car wreck, or they got hit in sports in the belly. Changing meds. Right. Something that's sudden. That's all of a sudden they've gotten constipated because 2 or 3 days ago they were having a bowel movement like clockwork. Now all of a sudden something's changed. That's acute constipation. And then chronic constipation we already talked about. Laying in the bed, meds, poor diet, poor fluid intake, all that. Okay. So just kind of know the difference. So when they ask you those questions, you can pick out the clues. If it's a 19-year-old football player that suddenly can't have bowel movement, that's. But if it's an 87-year-old on iron, lives in the nursing home, immobile, constipated, a lot different, right? Okay. A lot different worry level there. All right, I think y'all are good on all that. We've talked about a little bit of all of that already. Okay. So just make sure you look over your little thing. Keep these forever and ever, because they'll help you when you're getting used to your test. Moving somebody around, exercising, that helps the bowels move. Warm liquids, high fluids, high fiber, all that. Okay? Alright. Do y'all need a break real quick and then we'll listen to bowel sounds? You want a break? I do. Smoke break.
I have it, but
Document in the bowel movements. Document the same way you do urine. Color, consistency, odor, all that.
Don't hate he's like, listen, I have to be doing something I can pay attention to. I'm like, okay, I got out.
No, I know what else I was gonna say. I know a lady that I used to church with, and she went up to me and she's like, I went to do the during Sunday, and she's like, that doodle is just like little scribbles, like,
I do that.
don't like mindless drawings, you know?
I do that all
They
the
call
time.
it doodle.
It takes the nervous energy off and your brain can focus on
Yeah,
it.
and sometimes I'll get off subject because I'm like, my circle's not right. And then I this a whole thing. If you ever pay attention to me, I'm usually coloring or something. Joseph looks at my book compared to his book and he's like, should I stick up with it?
I used to do nervous doodling too. I think that helps.
Yeah.
I always make
It really
circles.
does.
Just make circles and circles and just keep going over and then I'm like,
But yeah, she like whenever I told her I'm listening, that's what she told me. Not today.
oh, I will send one today.
But you know what's funny?
tomorrow. That's why I was just like,
And we can do like farm questions. Y'all have farm questions.
I went home the other day and I was like, Dad, how's your prostate?
farm is not my subject.
I was like, Dad, are you, well, he's diabetic, and so he has frequency anyways. And my dad is normally like, Caitlin, I don't want to talk about that with you, but he was like, you know what? I think I am kind of having some issues with my prostate. He like made an appointment to go see his urologist.
That's funny.
Thanks for telling me that.
Donna, tomorrow, do you know where we're gonna be at?
What is tomorrow? Thursday?
I think we're supposed to be in the lab.
Yeah, y'all should be in the computer lab because Bretta has level 4 in the morning, and we're not going to be doing computer lab like the other people. And then I have them in the afternoon.
So we'll probably go to the lab.
Yeah, I bet y'all be in the computer lab and then skills lab.
Also, I'll come to tomorrow.
Because I'm tired, girl.
I want to get them out the way and give them to you. That way I am done.
Yeah.
Yes.
Yes.
I'm done.
I am with
Ahead of time.
So where are you going?
I don't know.
Just where are you going?
General speaking. You can interpret.
She really did that.
Shut up.
Is she back?
I was like, why would you do that?
Maybe taking your mom along.
I was like, I felt bad after I said she could speak in Europe. You're saying she's dead. I'm like, that's so. I believe Joseph. No.
But you really could. I think she'd be a really cool sport. Is how's your dad?
He's borderline.
Where's our Halloween candy? Did she return with it? This is all sitting out in front of me, Samantha.
She sure did.
It's free game in front of me.
I'm being bad today because I haven't used nothing green this morning. No roughage for you.
No roughage.
Hey, why don't we do complaining if you're complaining?
Right. No complaints when you're impacted.
I'm not gonna do any type of digital exam on you.
I hope not.
You can do it on your own stuff. Because we don't do this.
I don't want you to get carried away and try to simulate my nerves.
I'm so proud of y'all. Look how much y'all are retaining and you're using it in your conversations. That's how I know y'all are picking up stuff, because you start talking nurse talk. It's a whole another language.
You brought it.
I brought my lunch today.
What?
They don't have the tables up too.
Nursing school is a struggle. I can't buy nothing. Well, I could, but
I just heard salad, so I was like,
I brought leftovers from the house.
oh, I forgot my lunch.
Why do y'all share with me?
You need to go to Amigos and get that sweetbread and bring it back so I can sample it.
The best place is Frisco's Bakery. They make it fresh every morning.
How much is it? I'll bring you some money if you'll bring us some. Like, did you get up like a big loaf?
Yeah, you get a bags full. Bags full. It doesn't bag.
Leftover hamburgers.
So just bring us a couple and I'll pay you back. Cause it'll, so we can all like.
You can buy like 2 big old bags for like $10. It's like, it's good.
They're so good.
We can have them.
Good glass.
That can be. We can break bread next week for our Thanksgiving feast, and we can have coffee with it.
Yeah. I'll bring the film.
Like, I've never found a place here in Lava at all.
Don't ever buy from Amigos, because Amigos, if you've ever opened a Zip, there's so many lies in that deal. Don't do that. Don't ever buy from Amigos.
Really?
Yes, don't.
My grandma makes them.
my grandma does too.
But she's in Mexico right now. She don't want to come back. Hey, my Hispanic friends, do any of y'all make tamales? Yeah.
During Christmas.
Y'all will? Do you sell?
No, but I'll bring you some.
Because I love.
I make gonna try and make candy.
Tell mom.
Those are nasty. I've never tried them. They're the nastiest things ever. Like my family likes it, but I personally don't.
Like, okay, because she's from Chihuahua. She was gonna put pineapple.
Yeah, they put different stuff in it.
Which ones are nasty, or are they just?
I just think they're all nasty. Like the mud to me is supposed to be food, and
I'm just like, I said, you can do that, and she's like, yes. And I was like,
Does y'all mom ever make, like, when you're making the tortillas, like, you use the same dough,
What
but
else?
I don't know, and then you make it like a big old sweet bread. You add an egg, and they put sugar in it, and they make it real sweet. And it's not like making tortillas; it's like making a huge big old bread. It's not like sweet
Oh, we
bread.
make those for New Year's.
Yeah, we make it for New Year's too.
Are they crisp?
No. It says soft.
Menudo.
Yeah.
Menudo, yes. Like it's soft, and it stays in the big bread, and it's sweet.
That's not a menudo.
Oh no.
that's not a buñuelo.
That's what I always think.
You
You
said
said
soft,
soft.
but
They're not.
Yeah, they're not. They're
This is
crunchy.
soft. It stays soft. It stays like bread, regular.
What's a torta? Is that what she's talking
That's
about?
like
The torta is like a sandwich.
No, I don't like tortas.
I love
I don't
tortas.
either.
They're nasty. They're gross. They're really nasty.
I love everything.
Because you're from Mexico?
Yeah, we're not from Mexico. We don't believe
You know when Randall was like, don't drink the water from Mexico, I was like, I drink the water from Mexico.
We don't go to Mexico at all.
When I went, I went on a cruise one time, and I went to the it was like the island that's off of Mexico. What's it? No, not Cabo. Cancun, maybe? Is that the island? Anyway, we ended up going, and for the day, you got to go and look at the dolphins. And so they were having all the drinks and food and stuff, and all I had ever heard was, don't drink the water, you'll get diarrhea, you know? And so I was like, I can't have diarrhea. And so I remember asking the guy, he was like, would you like just that? And I know I insulted him because I said, where's the ice from? Because I was so scared that it was, you know, like contaminated ice water, and he looked at me like so crazy, and I was like, sorry. Yeah, that's what I was thinking, these stupid gringo. And I was like, oh my god, I'm so embarrassed. And then he goes, it comes from the mainland, like that. Like he all of a sudden just went off of me. I said, I'm sorry. I'll just take it hot. I don't care. Whatever.
We don't go to Mexico at all.
We do.
My family's not from Mexico. My grandma's from Mexico, but my grandpa's from Spain. And so my grandma was like, we're not going to Mexico.
Well, there's parts that are still like, I mean, it's nice and all, but there's parts just like here that are dangerous, right? Like you can't go, you'll get killed.
Into Mexico, which would be, how do you say it?
Fuerte?
No, it's,
Yeah, that's
Black
Negras.
Yes. Yes.
What is it?
Yeah.
And so
I don't go through that.
It's not
We
that,
go through
but
the
it's
real
still pretty.
it's kind of dangerous right now for any American to go anywhere, isn't it?
Yeah, it's, especially since I don't speak a lot of Spanish, yeah, I'd be screwed over it.
Why'd you have
They'll be like, you look Spanish, but you're fake Spanish.
Yeah,
You're faking it.
I'm Native American,
Oh,
and I look more Spanish than I do because I'm Sioux Indian.
And so, yeah.
The Dakotas, but from being in Texas, I look more.
Yeah. And so, do you speak Spanish?
My mom does.
Really? So you kind of know.
But she married a Mexican, so she knows Spanish.
And did she teach you Indian too?
My dad does. But my mom and dad divorced, so I never grew up with my dad. So it's just I don't really know that culture.
I would be so. We had a cultural question about that. That there was a young Indian guy that was in level 4, and he was. We had to look it up because it was like asking, you know, how do they their end of life wishes and stuff. And so I was like, I'm not real sure about like, you know, Indian culture, but I know that they're very spiritual. Like, how would you handle a body? So one of the persons in the group looked it up, and yeah, it was like all the special things you had to do for the body to prepare it. You can't take anything out. You come leave with what you came in with. It was really interesting. I have Indian somewhere in my family too down the line, but I think it's Cherokee because we were started on that end of the country. But I would go, if I went to Mexico, they would pick me off in a second. Hey, y'all! Ooh, I don't fit in. I don't fit in at all.
Yeah.
They would know. They would know. All right.
How long have you been in Texas?
This is our 4th year, so we moved here. This summer will be 5 years.
I would have never. Do you know, like when people move from like out of state into Texas, they still carry their accent? I would have never. I would think you've been here very.
Really good. I do hear it like a different dialect, and I really pick up on that real quick. But every now and then, like if I'm tired or I sound like, hey y'all, like Paula, what's her name, Paula Dean? It's bad. Like I let my guard down. And especially like if I talk to my sister on the phone, oh my gosh, we sound like two hicks. My kid's like, I can tell you've been talking to your sister because we're just hearing it. I guess you just pick up on it and you revert back to that.
And I love that.
You do? It was a fun place to live. People, just like here though, people are genuinely good. It's a genuinely good, they want to, the only thing I don't like is they want to feed you constantly, and I'm like, I can't eat anymore. But that's the thing. Everything in the Southern culture is around food.
Yeah.
You sit at the table and you talk for 4 hours. You can't get in and out of a restaurant because everybody sits and eats for hours. It's a very big cultural thing to eat. And so that's why everybody's overweight. We don't eat good stuff. So.
Guess what's going to be on our top 20
I don't know. We could have our cultural thing. We'd have a Southern sit down if you want to. After y'all do your scavenger hunt. I'm going to give y'all a list of things that are like...
What day do you want me to bring that?
Yeah, whenever you want to. Or Monday. You can do it Monday because we'll have lecture Monday. And then Wednesday we'll do...
They open early, too. Yeah, I'll go by there, and if not...
If you're late because you're bringing me bread...
I can do Monday. They're closed Monday and Tuesday.
Oh, it's okay. Just bring it whenever then.
Okay, I'll bring it Wednesday.
And if you can't do it Wednesday because of the holidays, we'll do it another time.
No, I can do it Wednesday. So Monday and Tuesday they are closed, but Wednesday they'll have fresh bread.
Ooh, okay.
Let's do Wednesday.
All right, sounds good to me. All right, is everybody back? Okay, so one more thing, just making sure y'all got the other handout that was in here yesterday, bowel obstruction. Did everybody get that? And it just has on there kind of what we were talking about. If there's something obstructing the bowel, it can turn into a paralytic ileus, which means paralyzed, because ileus is your part of your colon, ileum. All right, if they're blocked bad enough, remember we talked about it's going to come back up, right? So that's when they start vomiting. You'll lose sodium, potassium, chloride. That's what your electrolytes are, because those are in your stomach naturally. So if you're vomiting up, you're going to lose volume, so your blood pressure's going to drop, and you're losing electrolytes. And then we talked about the malodorous smell. The urine will be real strong if it has blood or something. A blockage has been there a long time. And it gives you little areas to look at and listen to, right? So now, and it talks about the bowel sounds. They're real high-pitched at first, and then they go silent. So let's listen to some online. And everybody, did you get a chance to look at the colostomy bag? You know that this peels off and goes on there. What's my main issue I'm worried about with a patient with these? Skin issues. All right, skin breakdown. Good. All right, let's see if we can hear these vowel sounds. I've not gone on this site yet, so I don't know. This may be poo-poo. Yeah, no pun intended. All right, so here's the story. This is a 40-year-old man with generalized abdominal pain. That's all we know so far. So let's listen. Right upper quadrant. Let's listen to it again. Hear 'em? It's like water bubbling, isn't it? All right, let's listen to the left upper. So first, what's in our right upper quadrant? Put your hand on your right upper quadrant. Gallbladder and now let's listen to the left. Still fast, right? Maybe it's all the same. This one says play. Restaurant sauce. Oh, okay, that's what you're saying. Oh my gosh. This man's about to have Code Brown. Alright, so that sounds... It's pretty bubbly, isn't he? what's the street term is bubble guts, according to Crystal. So what is the medical term?
Hyperactive.
I would say that's hyperactive. Let's see if we're right. Your observations are correct. Those are hyperactive. So did everybody hear how loud and bubbly and fast that was? All right, now here's a 60-year-old woman with constipation for 3 months. Poor thing. It says, came in 3 months duration. Her exercise tolerance has been decreased. She has coarse, rough skin. So what would that be a clue about? Right, she's dry. Blood pressure is increased. Pulse rate is 80. Swollen ankles. Lung sounds are normal. So let's see. Where's the bowel sounds though? Hello. There we go. All right. So I just click on one at a time. Y'all don't want to hear them all at once? Yeah.
Scroll up.
Skip. All right.
Let's see.
Not as fast as the other guys, is it? Are they as loud? No. So that's faint, sluggish. Not much to listen to, is there?
You could hear them, but they real.
Faint and kind of sporadic. You have to really listen. So what would you call that?
Hypo.
Hypo. Let's see. We are correct. There's a difference. Here's a 70-year-old man with abdominal pain, low blood pressure, and rapid heart rate. What do you think's happening with him then? Heart rate's up, blood pressure's down, he's 70. Blood pressure is 100/60, pulse is 120. Peri-umbilical pain on palpation. Peri means around, umbilical around the belly button. Let's see. Abdominal X-ray order. Yeah, the vital signs are your clue right there.
Did you see the slides?
We're in the right upper quadrant. All right, let's listen to this one.
He has IBS. IBS D to be correct.
What do y'all call that? What do you want to say? They do sound hyperactive, but remember at the top we heard that different sound. Hear that? It sounds like a.
What is that?
It's a brewing. I think it's a brewing. Is the pulse?
Normal valve sound with.
Yeah, and it's in the right up. It's in the upper quadrants only, because here it's in the right upper, and then listen over here. It's the blood flowing through is. It's your pulse, and you can hear it because. Remember, he's having peri-umbilical pain, so we're right around that umbilical cord. So maybe he has an aneurysm in that large blood vessel that goes down your aorta, the descending aorta, because you can hear that. That's a bruit, and then it's only in the top. So let's pick that one. It says normal bowel sounds with bruit and upper quadrant. I don't know if that's correct or not. Let's see. We're correct. So he probably ended up having some kind of aneurysm. All right, let's listen to Bubble Guts. Oops. Are y'all listening to any of this stuff when you're on your own at home? Listen to your lung sounds and your breath sounds and your bowel sounds.
North Big Mom's house.
I don't remember seeing that on the syllabus, Crystal. I'll have to check that.
You're supposed to not have a live person.
Right. Hello. Okay, I don't know. Let's listen. Oscillating. Oh, I have vowels. Here we go. Practicing. Sorry, this page is like really it's the one I wanted. There's ATI testing for abdominal exams. You can go to atitesting.com. Y'all can do those on your own. They have like little tutorials and stuff. It's kind of like what we did when we were in the lab that day, you know.
Listen for vowel sounds by placing the diaphragm of the stethoscope gently on the right lower quadrant. Listen to their pitch, quality, and frequency.
How do I make this big?
On the video screen,
Yeah.
where go up to your down, up a little bit.
If the patient has hypertension, listen for bruits over the right renal artery, aorta, and left renal artery. If present, a bruit would sound like this.
Yeah, we learned something there, didn't we? It's like air.
In a patient with hypertension, a bruit raises suspicion of renal artery stenosis, but most bruits have other causes. If you suspect arterial insufficiency in the legs, listen for bruits over the aorta, right iliac artery, and left iliac artery. Then identify and listen over the right femoral artery
This is way advanced than what we would be doing. This is
and left femoral artery.
you would not be all up in their business listening. It was the 70s. They were natural.
I might drink it when it's hot, I might drink it when it's cold. With a flavor so bold, you can feel it in your toes. Cold like a space soda.
Is that Marcus?
Like a space soda.
It kind of looked like he did. Marcus has got a side job. We didn't know. He likes Sprite.
Hi, my name is Adam. I'm a final year medical student. Can I ask your name?
Dan Stage.
Hi, Dan. I've come to do an examination of your tummy today. So I'll have a look at your hands, have a look at your face, and then have a press on your tummy as well. Would that be okay?
Yeah, that's fine.
Great. Would you mind taking your t-shirt off to begin?
Yeah.
Uh-oh, we're going to see some skin, ladies.
Okay, Dan, I'm just going to have a look at you from the end of the bed.
Disappointment.
Could you put your hands down by your sides?
He's not distended. The distension looks like they've got like a big swollen pot.
Okay, I'm just going to have a look at your hands, Dan.
It's real
So if you
tight.
could put your arms out for me like this.
So if they're real, because if their nail beds are real pale, they're iron deficient.
And if you put
So
your two
something's
index
going on
fingernails
with their
together, like
stomach.
that.
You're not absorbing iron. See, there's clubbing. See how rounded they look? They shouldn't be rounded like that, like ET.
That's great. If you turn your hands over.
And he's looking for liver, like signs of the liver. See, it's showing you what he's looking for. Liver damage.
If you turn your hands over again, extend your wrists all the way back and close your eyes.
You'll learn about that in level 4 because I just had to teach that. They'll have a flapping
That's great,
when their
thanks, Dan.
liver's damaged.
If you could raise your arms up for me. Okay, you can put your arms back down. Okay, Dan, I'm just going to have a look at your face. So if you just look straight ahead for me. And if you could pull your lower eyelid down with your finger. That's great. And if you look up at the same time.
And the white part of your eye will be yellow if you have jaundice part of the lid.
Okay, that's brilliant. You can stop doing that. And if you open your mouth and stick your tongue out and point it up in the air.
It's amazing how all this stuff is just to deal with your
And you
stomach.
can close your mouth, thanks. Just going to have a feel around your neck.
He's starting to get worried. Why are we looking at my neck?
I'm just going to have a feel of your tummy if that's alright now, Dan. Have you got any pain anywhere? No. I'm just going to flatten the bed. Are you okay lying down flat?
Yep.
You don't remember all those? You do. This is for the doctors who are doing the 6. Remember, we have the 6.
Okay, I'm just going to have a feel of your tummy now, Dan. Tell me if you're in any pain.
Yeah, 9, sorry. He's just doing a real thorough exam, but I just wanted y'all to see kind of how all of it's incorporated. And then he'll listen to bowel sounds too. See how he's palpating? He's pushing in deep. Because if you go in deep,
I'm just going to press a little bit deeper this time.
if it hurts, then that could be an internal organ is damaged or something's going on, inflammation.
Can you take some deep breath in and out for me now, Dan? That's great, keep going.
Kidneys are on the back, right? So he's kind of pressing down the front.
Okay, I'm just going to feel the blood vessel in your tummy.
Around the
I'm just going to tap on your abdomen.
That's percussion. It just, hear how it sounds hollow? Like, if there's a mass underneath there, it sounds dull. It sounds like a bop, bop, bop. There's a mass growing. See how it sounds like a little drum beating? That's normal. That's what he was talking about when we went to see Dr. Z-Dog. That's what his dad did. Remember he said he was a little Indian doctor and they did all that and he didn't even need an x-ray because he knew exactly where the mass was. So it sounds more dull.
If you roll over towards me. That's fine, you can lie me back again. I'm going to have a listen to your tummy now, Dan.
Finally. So they're completely absent if there's nothing, you can't hear anything in 2 minutes.
Okay, Dan, that's the end of the examination. Thank you. You can get dressed again now. Thank you.
We'll do it on the patient. I mean on the mannequins. I got corrected. Exit.
It's showtime! Did we order Chinese, Greek, and Italian food last night? And hot dogs. Ugh.
In summary, I examined Dan, who's a 28-year-old male. He had no peripheral stigmata of GI pathology. His abdomen was soft and non-tender. There was no organomegaly, and bowel sounds were present. This is
one for nursing too.
Now that we've gone over how to properly make sure that we are following the steps for abdominal assessments and abdominal sounds here, we are going to go into the bowel sounds. Bowel sounds. I. I stands for inspection. Okay? This is the proper order. And here are my eyeglasses here. For inspection, we want to make sure that we're looking at our patient. They're lying on their back, right? We're looking for any discoloration or anything like that. Make sure that we follow this in the proper order. So the next thing we're going to do is listen. That's auscultate or auscultation, right? That is your ear there. So we have our eyeglasses in our ear. And what are we listening for exactly? Remember, we have bowel sounds. These particular bowel sounds happen every 5 to 15 seconds, okay? Basically with that, we want to make sure that we're listening to our patient in all 4 quadrants of their abdominal region, okay? With that being said, let's say we have a patient who is experiencing issues with their abdominal region and you don't hear any bowel sounds. Make sure you listen to that patient for a minimum of 5 minutes before you rule out that there are absolutely no bowel sounds. Next thing is percussion. So I'm going to draw my little drum here and my little drum sticks. Okay? We are doing a percussion and light tapping on the abdominal region for sounds of air or hard sounds. Okay? Sounds of air or our hard sounds. And we're going to talk about different diseases where you hear different things during these assessments, okay? Percussion, we've gone over that. The next thing is palpation. So our patient, we are checking, we are feeling their abdominal region, and we are checking for tenderness.
It's supposed to be IAPP. Looks like BD.
All right. So let's go ahead and go on to the next video so we can continue talking about all of the different diseases and the nursing processes for each and what you're going to need to know for your test in a quick, succinct fashion. Okay, again, my name is Coco Christie, and I'll see you on the next video. Click on the link below and go ahead and grab your video, and I will see you, grab your gift, I'm sorry, and I'll see you on the next video.
I don't know if I like Coco. I want to hear sounds. Why is it so hard? We need to start giving them a thumbs up and down. We need to start reviewing all these folks. We need to make our own. We can totally do this. Star Wars. That's exactly what I was thinking. I feel like I'm watching Star Wars credits roll by. Hello, come on. Okay, I can't handle this. Good idea. Stay with this. Alright. What can I type in that will make us do that? Listen to bowel sounds. Why is that so hard? Well, let's try this one. And then we'll go practice on
Did we order Chinese, Greek, and Italian food last night? And hot dogs. Ugh.
I'm not making tater tots.
They're organic.
Basic tutorial on
listening to bowel sounds and inspecting. So basically, you're going to have the patient lift up their gown, cover their private areas, give them privacy. You're going to inspect the abdomen, see if any scar tissue or anything, see any abdominal distension. You want to also look at the aortic artery to see if it's not pulsating too much. Could be a triple bypass or something. And then you're just going to take a listen over here, listen for any sounds, gurgling or anything. They might be hungry or it could be gas or something. And listen up. Same thing. If you don't hear anything, just wait maybe at least a minute to hear. It could be hypoactive. But if you want to make sure, it could be like bowel obstruction. You might have to listen for up to 5 minutes. But it just varies. And you just have to listen to the 4 quadrants separated. And after that, you're going to take a feel and then ask the patient if there's any pain felt. No pain. Okay. And you're also feeling any tender or if it's distended or anything like that. And that's about it.
Yeah. Number 1, needs to be quiet in the room. Alright, so let's just break off into groups. Y'all can do your independent study, and we'll go off in groups and listen to the bowel sounds on the mannequins. Y'all can study for farm, or sweat your honor. I think that's going to be that might be a good grade, good project for the next group. They can make their own YouTube videos, like on different things. That'd be fun.
Extra credit.
Or like, well, we can't give extra credit, but I can do like instead of doing those stupid papers.
Let's do that.
Put it down
Extra
for us.
papers.
Let's just drop them right now. So,
Drop it like a rock.
out the window.
I'm gonna start my video right now, y'all. Project Frenzy. I'm gonna talk about Frenzy. It's so hard. I'm just gonna write the paper. You just gonna have to give me whatever you feel.
All right, so if y'all want to go listen to